Our next speaker, a lot of you are going to know. It's Katie Lewman, who's our Education and Outreach Manager. She's very passionate about improving HPV rates and as well as improving rural health, and she's going to talk today about recurrent respiratory papillomatosis, which is something I had not even heard of before I started working at ISDH, so it's a lot of good information. So welcome, Katie.
Well, thank you for letting me speak to you about a rare disease. So it is juvenile onset recurring respiratory papillomatosis. So if you want to impress somebody, you go home and say that. But it is JORP for short. Oops, I should use my thing here. So the learning objectives is it's a rare disease. Not many people have heard about it. So we're going to talk about the epidemiology, as well as include how it's diagnosed and any treatments. And spoiler alert, it is vaccine preventable, kind of, sort of, in an indirect way. So we will talk about ACIP recommendations. So as I mentioned, it is a rare HPV infection of the respiratory tract, primarily caused by subtypes 6 and 11, which if you've been vaccinated for a while, you know that's associated more with anogenital warts, not in the respiratory tract, but it can happen. So it can be one papillomatoma or many, but the larynx is the most common site for the infection. That's where they see it most, but it can be anywhere along the respiratory tract, so even down in the bronchial tubes. Of the two, both can, it's rare, but can develop into cancer, but of the two, 11 is the most aggressive. And like all HPV infections, it's can go into remission, that your body can clear it. There's no clear reason why it does that. Is it nutrition-based? Is it hormone? They don't know. It just does. So we'll talk a little bit about HPV 6 and 11. That is not a rare infection, but the papilloma or the warts can be either flat, they can be raised, or they can be on a stem, which is the pedunculated. But it can also be asymptomatic. So while your body is clearing it, that virus is still shedding. So that means you're infectious. But it is unpredictable for that reason, and it can take up to 2 years for it to clear. The incident rate, it's very common, as I mentioned, but about 6 in every 1,000 people years is the incident rate, and that's for males and females from ages 15 to 40. And women, actually, that rate peaks at a younger age for the women than it does for the guys. So recurring respiratory papillomatosis is split into two groups. So adult onset is the infections assumed to have been gotten or diagnosed after age 13. The juvenile onset is younger than that. But of the two, it's the most severe. And the reason why we're presenting it to you today is because pregnant moms can give it to their unborn babies, and that's called vertical transmission. So vertical transmission is obviously associated if somebody has a genital wart infection while pregnant, but moms with a history of it are 231 more likely to get to have this problem with their children. But the triad, it's young moms, moms under 20, it's their firstborn child, which typically you have your firstborn child when you're younger, but also vaginal delivery. But a cesarean delivery is not a fail-safe. It has, the HPV has been detected in amniotic fluid, so we know it can cross into other fetal tissue. So what are the risk factors for vertical transmission? So this study, over 100 patients, 153 healthy moms were followed, and for inclusion in this study, they had to get 2 to 3 pap smears, one for each trimester, and then they tested their children, the neonates, for HPV infection in the blood, cord blood, or the nasopharyngeal aspirate. So the results of that study. About a little over 5% transmitted the HPV infection to their kids. So of the 153, it's eight moms. And this one, because there was only 153 versus 153,000. In this case, though, the cesarean deliveries, there were more cases of the HPV infection than the vaginal. But HPV DNA detection during pregnancy was associated with moms having an HPV infection and giving it to their children. So just some statistics, and the ones I'm presented here, I know 1995 is kind of a while ago, but what I found while I was researching this is it's rare, not a lot of literature on it, but this task force has done annual projections, and this is what's included in a lot of the literature that's published today. But they projected that the incident rate would be 4.3 per every 100,000. Thousands of new cases, lots of active cases, but the two at the bottom are the ones I want you to focus on here. So like over 16,000 surgical procedures to treat this disease, and it's millions of dollars to do that. So this group actually looked at insurance claims data. So when this was collected in 2006, it was probably ICD-9 coding, but what they were looking for was coding indicating a recurring respiratory papillomatosis diagnosis and or treatment. So the incident is the new cases, whereas prevalence is everybody. And they separated it. They took one that was a private insurer and checked those claims data and compared that to a Medicaid group. And it's over 1 million in each one and almost 2 million in the private group cohort. But even though the Medicaid rates were higher, the disease severity was about the same. So this infection is no respecter of persons. Socioeconomic status will not protect you. So some of the symptoms, hoarseness is the most common. But as you're looking through this list, you see these are very nonspecific. But the stridor, the chronic dyspnea, any of those things indicate that there's an airway obstruction, and if you're not getting oxygen, that can cause other problems. But specifically in infants, you're looking at a weak cry, coughing fits, and the failure to thrive. So what it's commonly misdiagnosed for, and I did not put these in alphabetic order, but asthma is actually the most common misdiagnosis for this condition. And, but allergies, just anything that causes a chronic cough. But I wanted to, something specific from some of the readings is just that pretty much if you have a child who has some kind of breathing, pediatric airway disease that's not responding to treatment, not following the natural disease progression, that sort of thing, this is something that you should be suspicious of. So how is it diagnosed? Here are some of the fun treatments that they have, or diagnostic tools. So the small mirror, I included that. That was actually mentioned. It's an old-timey way to just look down the throat and see what's going on. But the best one is actually to put the child under anesthesia and do a direct laryngoscopy. I knew I was going to stumble on this. You know what I'm talking about. But anyway, get down there, look around, and biopsy it. So that's the primary thing to do. So this would not be a vaccination training without gross pictures, right? So they're going to pull up the link here. This is on Medscape. It's a free article. So he's going to click on the picture. So what you're looking at, the little white guys on either side, that's the vocal folds. And you can see the papilloma there. So he's going to click on the next picture, and we get to see a video. And you can see how it pops out when the vocal folds close. So, yeah, that's what's causing the stridor, the hoarseness, and all those things. So, very unpleasant. So the thing is, there is no cure. We can treat it, they can remove the papilloma, but there's no cure. And the laser removal is preferred because it prevents scarring, it's less likely to be scarring. The microdebrider, if you're not familiar with that, that's like somebody actually kind of pulls it up and raises it off, and then there's a little blade that cuts off the growth. But in severe cases, a tracheotomy might be required. And as they know, the warts come back. They don't just go away. And it's not uncommon for somebody to have multiple surgeries in a year and multiple surgeries over their lifetime. So this isn't just something you go in a day or two, you feel better. Their throat is raw, and it's raw for weeks, while it's healing. And I've repeated some of the numbers on the treatment because I keep going back to this is very expensive. Not only are there thousands of surgical procedures each year for these patients, but it costs millions of dollars. This particular study, what these guys did, they looked at claims data in Maryland. It was specific to that region. But what you're seeing here on the bar chart is the first group is the lifetime costs, and the bottom one is the annual per patient. So lifetime per patient, annual per patient. So the green is the high. That's obviously your outliers. The blue is the low. Those are the lucky ones that should go out and buy lottery tickets. But the red is your average. And if you'll look at the annual cost per patient, that number is $47,000 plus. And I was trying to think of things, how can I put that in perspective? Well, the average income for a Hoosier is about $50,000 a year. So basically what the average person makes in Indiana each year is how much it costs to treat a patient each year. So it's preventable, guys, almost 100% if they get vaccinated before the mom gets the infection. So the universal recommendation is 11 or 12. I know y'all have gotten some pushback from parents, why so young? And it's like, the idea is we get it, vaccinated, get those antibodies going before the kids are exposed to these diseases. We don't expect them to have their sexual debut that young. It's, those are the rare ones. But we do expect as they age, when they get 18 and older, they're growing up and getting married and doing things married people do. So we want to get them vaccinated. Depends on how young they start, and this is also a good sell. The younger you are, it's 2 shots. Ask any teenagers, would you like 2 shots or 3? So give them 2. And wanted to talk about the cost. And we're not comparing, contrasting CDC and private. I wanted to put those up there. But what we're comparing is the cost for the vaccine series compared to the treatment, which is at the bottom. So you can see whether you do a 2-dose CDC price list or a private 3-dose, you can vaccinate 75, 100, or more kids for the cost to treat one patient over the course of a year. And just another little economic perspective here, because I know there's some practice managers out here. So when you vaccinate, you protect that patient, right? That's a 1-for-1. But when you vaccinate, you're protecting these kids against potentially giving them a miserable disease that's not curable, as well as the cancers. Well, we know that out there too. So what you're getting for there, you're not getting a 1-for-1 at that point. You're getting a 1-for-many. And they call that the social benefit. It's harder to put a dollar figure on, but understand you are not just protecting that particular patient, you're protecting their offspring and the future people that they love and care for. So in just conclusion, it's a rare disease. It is. The infection is not. And the morbidity and the mortality, while death due to an HPV 6 or 11 cancer is rare, the morbidity is bad, and it increases the later it's diagnosed, the more severe it gets. But vaccinating adolescents can prevent it. It's a juvenile onset as well as the adult onset. So just for, if you guys, does anybody here watch TV besides me? Maybe 1 or 2 of you. I know you're not putting your hands up, but I know you do. So Discovery Health has a mystery diagnosis show, and this is actually one of their mysteries. And what's interesting, the kid didn't get diagnosed till he was a teenager, but he had trouble as a youth, and it was the same thing. Got the asthma, got the inhalers. It would help a little bit, but not really. Went into remission, came back with a vengeance when he was older. But that's something, if you have Discovery Health Channel, that's something to kind of look for. But well, I thank you. These are all the works cited. And do you have any questions? All right.
All right, well, thank you, Katie. For those of you who came in a little bit late, please make sure you've signed in on the sign-in sheet that are in the center of the tables, and please put your VFC pin, otherwise you're not going to get credit for being here. So we're going to take a short break. What time do you want to come back? 3:15? Okay, so if everyone wants to be back at 3:15, the restrooms are down to the left. Take the escalators down, and they'll be right on your left. Please visit the exhibitors' tables. They have lots of giveaways and things like that. So meet us back at 3:15.